if CDC goes away or isn't effective, what's going to happen to that? There may be vaccine guidance that can't be trusted. There might be data that is delayed. We need to speak up about as doctors, is we're trying to take care of people and populations.
Dr. Debra Houry is a former acting directory and the chief medical officer of the CDC. Dr. Houry guided dramatic growth in resources and impact, advancing national strategies on opioid use, suicide prevention, and mental health.
I'd heard you say in another interview that you guys were trying to raise the bat signal to the nation and to the world. What are you trying to say?
This is not political. This is about ideology. And this has to do with people not believing data and science, being unethical and doing things that are not valid and that could hurt people. CDC's programs are being cut, and 80% of CDC's funding goes to state and local health departments. As budget cuts happen, there's going to be a significant ripple impact across the nation and communities. We need more voices out there taking a stand right now. Silence is not helpful in this moment. I know it's uncomfortable for people to speak up sometimes, but it doesn't have to be political. Scientific integrity is not political.
Welcome to the Interesting MD podcast, the show about what doctors do when we aren't seeing patients and how this can help us find balance and prevent burnout. I'm your host, Rob Beck. Welcome back to another episode of the Interesting MD podcast. I am your host, Rob Beck. Today is the last in the series of episodes that I've called the What the Hell is Happening in the U.S. My first guest was journalist and author Stephen Marsh, who spoke about political violence in the United States. And the second one was Dr. Dimitri Daskalakis, who resigned as the vaccine director at the CDC. If you haven't listened to those episodes, please go back and take a listen. Before we get to Dr. Debra Houry, I would like to take a minute and introduce a new segment here on the podcast where I answer some listener emails. This first question is from a listener, and it's related to continuing medical education and maintenance of certification for doctors who moved to Canada from the United States. I'm going to keep these anonymized as people don't really want others to know that they're searching or thinking about moving to Canada. But today's question was an email. Says, Rob, I am a physician in Washington State. I am so grateful that I found your podcast. I've been looking into moving to Canada for several years, and it has become more urgent recently for reasons that are all too clear. Geographically, I was most interested in British Columbia, but up until recently, it seemed like one of the harder provinces to move to and work. Things have gotten much easier. Thank you for your podcast on the issue. I've been getting information in every way that I can. My question is this. I'm board certified by the American Academy of Family Physicians. I am wondering if you know, after we move and start practicing in Canada, do we keep our American board certification or do we somehow convert to a Canadian supervisory boards for this? I think it may be difficult to get CME, but not impossible to keep an AAFP board certification. Thank you. I hope you are not getting too inundated with letters. I know there are many of us trying to follow in your footsteps. First of all, thank you very much for your kind words. I get this question a lot, and I am not getting too many emails, so keep them coming. I do have some good news for you. In the provinces that I know about, specifically British Columbia, Ontario, and Nova Scotia, but I suspect that it will be all of them, once you're granted a license to practice in your province, you will be entered into the appropriate college for maintenance of certification. For family medicine doctors, you will be under the College of Family Physicians of Canada, and everyone else will be under the Royal College of Physicians and Surgeons. I can speak very easily to the Royal College and can say that it's a pretty easy process, especially after undergoing a revamp. For family medicine doctors, you will be under the College of Family Physicians of Canada, and for everyone else, you'll be under the Royal College of Physicians and Surgeons. I can speak to the Royal College and can say that it's quite easy, especially after undergoing a revamp in the last couple of years. You earn credit in 3 different categories, and you must do at least 40 credits per year. You report these online or via an app. It's a pretty painless process and can get credit for a lot of different activities. I don't know the specifics of the family medicine maintenance of certification, but I assume it's similar. I have let my ABIM certification lapse in the US as it became too much trouble and I was already working here. In many cases, you're not going to be board certified here in Canada, but you will absolutely have an unrestricted license and practice independently and will be treated as a full member of the Canadian healthcare system. But you will be required to maintain your certification like everyone else. Thanks so much for your question. I hope that this helps. If you have any other questions about moving your practice to Canada, what practice is like, what life is like, or if you have something else fascinating you want to discuss, please reach out to me at rob@interestingmd.com. Again, rob@interestingmd.com. For today's episode, I sit down with Dr. Debra Houry, who has recently stepped down from her role as the Chief Medical Officer at the Centers for Disease Control and Prevention. We'll delve into her experiences at the CDC, explore her insights on the transition of the CDC under the Trump administration, including what happened with DOGE and the problems they faced when RFK Jr. became HHS Secretary. She resigned in late August, along with two of her other colleagues, who did this as a way to raise the bat signal about the dangers of the new policies of the administration. Whether you're a healthcare professional or simply curious about what is happening to health policy in the U.S., this episode is going to offer some valuable perspectives. I hope you enjoy this conversation with Dr. Houry as much as I enjoyed talking with her. Please take a listen. All right, Dr. Houry, thank you so much for coming on. I really appreciate you being here. It's truly an honor.
My pleasure. Thanks for having me.
Yeah, thank you. So where are you coming to us from?
Atlanta, Georgia.
All right, so you're still in Atlanta. Okay. Can you just tell us a little bit about yourself? For those who may not know who you are, where you kind of where you came from, where did you train? We'll talk about how you became the Chief Medical Officer and the Acting Director of the CDC here as well.
Sure. So did medical school in New Orleans at Tulane, got my MPH as well. And then
what year? Sorry, because I did too.
Oh, really? I graduated in 98.
Okay, in 98. Okay, so I started in 2001 in my MPH. What program were you in?
Health Systems Management.
Health Systems? Okay. So was Tom Farley there at that time? Was he still?
No, but I knew Tom Farley when I was at CDC. So.
Oh, okay. He actually wrote a letter for me to go to medical school, so I'm
very
super
nice.
honored. But so my wife and I both started our MPH in epidemiology in 2001 and went to med school at Tulane. We did it the expensive way, where we paid for both of them and not inclusive.
Yes,
so.
I did the 4-year, no additional cost for MPH.
Yeah, that was smart. Okay, so my apologies.
So went to Tulane and then went to Denver Health Medical Center for my ER training, and then took a faculty position straight out at Emory University, where I had a dual appointment in School of Medicine as emergency medicine, and then in School of Public Health, where I was teaching classes, doing a lot of research in the emergency department around preventing violence, intervening for things like post-traumatic stress disorder. Loved what I was doing. Even was in the provost office as the University Senate president and ran some leadership courses, had NIH CDC funding, was tenured. But then a job at CDC opened up, and it was to run the National Injury Center. And that had, to me, just a lot of appeal because it took some of the things I was really passionate about and have that national scale. And so I applied and actually got the job while I was interviewing. They said, great, we'll have you start. And so,
wow.
I was not expecting that. So I joined and stayed in that role for about 7 years and built up the suicide prevention program, overdose prevention program. The firearm research program was the first time it was funded in 20 years. We were able to get that done under the prior Trump administration. So lots of great work that center did. And then the number 2 at CDC retired. Dr. Ann Schuckett and Rochelle Walensky was the CDC director at the time, asked me to step in. I said I'd do it for a short time. So I agreed to do it as acting and did that for about 2 years, which included leading the CDC. Yeah, I think I kind of knew that was going to happen when I agreed to do it, but wasn't quite ready to give up the injury center. And then led a lot of our reorganization at CDC for the lessons learned post-COVID. So on data modernization, some of the lab quality issues, response. And as part of that, we saw the need to have a chief medical officer, somebody really focused on overseeing all the national centers, program and science. And so I agreed to do that permanently, which I did for 2+ years.
Wow. That's very impressive. Well, thank you so much. So when you were at the CDC and you were part of this reorganization, can you tell us what the CMO does? Because I didn't realize that was a new position, but can you tell us what the CMO and the acting director do and just how the data at the CDC impacts the lives of doctors and average citizens? I think when people think about the CDC, they think, okay, vaccine recommendations and things like that. But what are the other everyday things that
affect people's lives, both physicians, because this is kind of a physician's podcast, but also for everyday citizens?
Yeah, no, great question. And that was one of the things that kind of drew me to having this position at CDC, because it was concrete and really spoke in my mind to what physicians needed or could have access to. Sometimes I would read long papers and think, okay, so what am I supposed to do with this? And so my lens as the chief medical officer was translate it and make sure that things were really applicable to clinicians. So you knew kind of the what's in it for me, what do I take away from it, how do I help my patients? So I oversaw the 9 national centers. So all of our infectious disease work, which included our vaccines, non-infectious, was included like chronic disease, environmental health, injury and violence, occupational health, and then the Office of Science. So all the scientific publications that came out. So things like the Health Advisory Notice, the MMWR, or the Morbidity Mortality Weekly Report. So those came through me. And then all of the clinical guidance I would sign off on and make sure that truly, over the past 2 years, we were focused on clear communication and what were the takeaways. So you would notice, like, even in the MMWRs, there were kind of more of the boxes. And I started a Chief Medical Officer Clinical Pearls newsletter once a month to distill some of the findings from the MMWRs into, like, what are some of the things clinicians need to know? Because you're busy, don't have time to read every single weekly report. And the Health Advisory Notices, we wanted to make sure, too, there was a takeaway. What do clinicians need to do if they have this type of patient? What do they need to be aware of? So that was one of my large focuses. And then, there's so much great work that was being done at CDC, so like environmental health, PFAS, an environmental issue. That center developed guidance for clinicians, like on how to screen patients, what to do at different levels. And they did that in collaboration with the National Academy of Medicine. So that was something I oversaw, as well as there's a heat and tracking tool that came out to where on your app, you could see what happened with hot temperatures and when you needed to worry about health consequences. And so that was done in collaboration with many physician organizations, health departments, so that both people in communities, but also clinicians, knew how to advise their patients on things like asthma, storing medications, cooling centers, just how to prepare.
So during the summer, this is something that, like, during the summer, we're focusing on protecting citizens, and we're giving out guidelines and warning about heat advisories and what doctors should do, what health officials should do to try and help those people. Is that
absolutely. Yeah. And then, another example is the Injury Center has a really great dashboard on drug overdoses. And you can look at it at the local level to see, is it fentanyl? Is it amphetamines? What are driving the overdoses? That way, if a patient comes in, is naloxone going to be successful? How many, if it's going to be fentanyl, do I need to have that on my mind? Is it poly substance use? Is it going up? Is it going down in the community so that you're able to be responsive? So really looking at data like that, and then dashboards on things like measles, even wastewater for different infectious diseases. So you can see what is happening in my community as both a individual, but also as a clinician.
Okay. So this is impacting everyday people's lives. This is not just doctors. This is not just vaccines. This is overdose prevention. If you're in the southern U.S. and you're working outside in the heat, you are affecting people's lives. You are doing things to affect every single citizen.
Yeah. And I think what's unfortunate is right now during the government shutdown, a lot of those day-to-day activities aren't happening. Certainly outbreak response is, but as you and I are talking, we don't need it right now in the fall, but the heat tracker, they wouldn't be updating their data regularly. Some of the drug overdose work is not going to be done regularly. Even things like, respiratory, like COVID virus, since that's not a program-led response right now at the agency, that's not going to be updated. Measles will be because it's still an agency response. So that's kind of the difference right now is during the furlough, a lot of these activities are paused. And what concerned me, around many of the changes at CDC is many of these programs are slated for elimination, which will have significant impact on the U.S.
Wow. And I'm hoping that that's something that we can talk about that process and about how you see that going. It's incredible to me that this is the end of October, that, Halloween is tomorrow. So October 30th today, and that the government shutdown is still ongoing, that we are now talking about the lack of there's no end in sight at this point. It doesn't seem. So these people are really starting to be affected, and especially going into a respiratory illness season, that this is going to affect a lot of people. And that's what I'm really hoping that people get out of this. Fast forward to the beginning of, or the end of January here, where you have now become the acting director. Is that just because the CDC director kind of resigns? Is that kind of standard policy, or how did that happen?
Yeah, so the CDC director is a political appointee. And so every 4 years, they submit their resignation letter. And I think in every case it's been accepted. And then they designate who an acting is, knowing that the new administration can come and appoint somebody else. And so I was acting for under a week because in the Trump administration appointed Dr. Menarez as acting director after that. But I was the transition lead. And so what that meant was I was the one that was meeting with the presidential transition team from the department and really shepherding the agency through the changes. So when we had new priorities, trying to brief new administrations, new politicals, that was my role. And it was a different kind of transition this year because, we had an acting director who then stepped away for confirmation and then came back as permanent director, and then subsequently was terminated. And so it was a very prolonged termination. And the other thing that was different is usually CDC will have 1 to 3 politicals. Currently, I believe there's about 12 political leaders at CDC. So very different. The agency was open to change. I read RFK Jr.'s books. I read many of the papers that had come from American Enterprise Institute Heritage Foundation. We looked at how some things, could be scaled back. Things around chronic disease, infectious disease preparedness, working with private sector could align with the secretary. Unfortunately, he was not interested in meeting with career scientists. I never had the opportunity to brief him, as neither did several of my vaccine scientist leaders. And many of the decisions being made around the future of the agency are being done without the input of CDC career leaders.
Can you take us back to that time where the transition first started happening? Like with DOGE, I assume that you ended up spending a lot of time with the Department of Government Efficiency. Sorry, I roll my eyes as I think about that. But could you walk us through what that was like? Did you have a lot of interaction with them? What happened?
I had some interaction with them, not as much as several of our acting chief operating officers, but since I oversaw all the programs, I was asked for my input on, where we could take cuts and so forth. And just to be upfront, from the beginning, the staff were prepared for 0, 10, 20, even potentially 30% cuts in different programs. Unfortunately, much of what we had proposed is not what happened. And so I think that's where there's difficulties is, sometimes we might recommend trimming part of a program, but with how these cuts were done, it would take out an entire division instead. And so that made it difficult to really scale things back. Instead, it just made it come to a complete halt. So I'd say that was difficult. There were several times we did appeal to DOGE and were able to save jobs in some programs. I think for me, it wasn't just the cuts in the executive orders, though. It was some of the scientific and clinical issues that I started to notice. We started having the first measles cases. Normally, a secretary would want to be briefed. We would send the information up to the department and didn't, have any requests for briefings from the secretary on measles. And then, he misspoke several times and said, there were fetal parts in vaccines and the vaccines were killing people. And this is during a measles outbreak. And so, I wrote up some talking points to help to see if, he would talk about vaccines in a positive way, particularly during this outbreak. I sent it to our leadership. I don't know if the secretary received that information or not, but every time he said things that were incorrect, we did send up corrections. And I think what was also disturbing to me was, he's promoting vitamin A a lot. And vitamin A does have a role when it comes to treatment, but it's not prevention of measles. Vaccines are. And so when you're promoting vitamins over vaccines, that's not what I would do, as we're seeing cases increase. And then Texas, some of the communities were reporting vitamin A toxicity. So there's harm. And we were also asked to consider repurposed medications for clinicians. So things like budesonide and clarithromycin, because healers in Texas were using them, but there was no evidence to use those. And so we said no. And so I think that's when I started becoming concerned about data and science. I'm all for looking at new treatments, doing things differently, but we have to follow science. And particularly when there's adverse consequences when you don't.
Yeah. Clarithromycin and viruses don't usually have any
No.
interaction. They're
And
ships
budesonide,
passing in the
surely if
night.
there's, a reactive airways component that might be helpful, but otherwise in general, not. So
Right. Oh my goodness. Okay. And is it pretty normal that you would send up talking points to
no.
kind of the principals?
Well, yes, I take it back. We actually would, like if people were, anytime principals were talking on things, over the years, we would get asked for talking points. Usually we weren't proactively addressing, misstatements, but
right. Yeah. You weren't
general,
saying, okay, so that
yeah.
wasn't correct in any way whatsoever. Can you please correct
Yeah.
this? Stop vilifying us. Thank you.
I
Okay.
was monitoring X for a bit. And then anytime I saw something about, there was even a tweet about locking a researcher up in a windowless room, 90 degrees. And so I went back to our team and said, please outline for me, what did and didn't happen. And then I sent it to our media and legal teams just so that they were aware. But that was something, that's not how I had envisioned my chief medical officer role, doing things like that.
Things change quickly. Can you talk to us a little bit about the shooting at the CDC? Because I've been focusing about the past few weeks on this podcast. We've talked about political violence and about kind of the vilification and trying to talk to U.S. doctors about where things are headed and what's happening and why are we becoming vilified? You've already said on here that you've been told that, or the doctors were told that they were the problem, the vaccines were the problem, you're hurting people. This comes out all the time, the things that we are doing. I get these comments on my YouTube all the time that doctors are hurting people and that they are, they're the enemy. So I think that this is the only natural progression of this, right? And as an injury prevention and a violence prevention person, can you just talk about this and your thoughts?
The shooting was devastating for the agency on so many levels. One, it was a result of COVID misinformation. And violence is never the answer. When discussions become violent rhetoric and result in deaths and injuries, that's completely unacceptable. And Officer David Rose lost his life protecting, our CDC family. The CDC shooting, there were 500 rounds fired, and each one of those was meant for a person. 180 plus windows were hit. I walked the campus and saw glass shattered. I saw bullets, in the doorways of my colleagues' names. Devastating to see. And I talked with many of our staff. One was in the daycare parking lot covering her child when bullets were passing over her head. Another person, saw every time he moved, he felt like the bullets were being aimed for him. So he's hid under a filing cabinet. This is what people went through. And then they stayed on lockdown for several hours as federal marshals cleared floor by floor by floor. So they were under lockdown for about 5+ hours. I called in FaceTime conference rooms where hundreds of people were sheltering in place, trying to offer comfort and letting them know we were doing what we could. But it has impacted the entire CDC community, whether people were there or not, because it was a direct attack on CDC. And so many scientists and other, program officials after that didn't want to speak publicly about vaccines or other political, potentially polarizing issues because they feared for their own safety. And we're looking at taking their names off papers. At the vaccine committee meeting, leaders started presenting instead of scientists so that there would be more anonymity for them. So this has long-term repercussions. And then just looking at from a violence prevention lens, an incident command structure was set up focusing on mental health response. So looking for resiliency, counseling, support for staff. The first week, the campus was closed so that people could recover and so that a safety assessment could be done. But many of the staff still have acute stress reactions, to this and required counseling. Unfortunately, the group that does violence prevention, particularly the firearm violence research group, was permanently terminated 1 week after the shooting. And the people who provide mental health counseling through the Employee Assistance Program were a part of the October 10th reduction in force.
How entirely tone deaf a gun violence prevention task force division to protect all Americans. It doesn't matter what side of a political spectrum you're on, to prevent all Americans and to prevent violence against all Americans. And they just terminate that. They get rid of that division.
Yeah, it was disappointing because that was one of the programs that I helped stand up under the prior Trump administration, and a focus on things like preventing veteran suicide, safe handling, for children who participate in athletic activities with shooting. So it was very bipartisan, very focused on science and protecting people's rights to own handguns if they wish to. And so there was no infringement. There was no advocacy around it. No gun control. It was science, data, and protecting people. Those programs won't continue in the United States. And we know firearm violence is still a significant problem. I think that's what causes me heartbreak around the CDC is, many of these great programs are being cut. And that impacts all of us as clinicians and as community members, as a mom, as a wife, a neighbor.
I've said this before on this podcast, but I was in a mass shooting on Mardi Gras Day in New Orleans with my 2 kids, and I cannot imagine what you guys went through. And this was something that we lived in fear of all the time. There was a study out of Colorado a couple of years ago that said, or maybe earlier this year, that estimated that about 2% of all Americans, 1 in 50 Americans, has been injured either in a mass shooting, either directly shot or in a trample injury. Does that, again, that was data that was in Colorado that was kind of generalized to the rest of the United States. Do you find that that would be a reasonable estimate? I feel like you're probably the expert.
Yeah, I'm not sure about that specific example, but I do know when you look at firearm deaths, most are due to suicide, and mass shootings account for under 2%. So I think if you're looking at all shooting type injuries, that could be. And I think, any exposure to this type of violence, it's preventable. And I think that is what needs to be realized is it's preventable. There's actually in New Orleans, there's some great community violence programs that have decreased a lot of the violence. And in Colorado, there's a great gun shop project that CDC had funded, looking at how gun shop owners could look at people at risk for suicide and have conversations with people and engaging gun owners. And I think there's so many ways the community can be engaged. And that's some of the great work CDC has done around, occupational health, environmental health, reproductive health, and those programs, have been cut or are slated to be cut. And that was just one of the many reasons why I left.
Okay. Yeah. Would you be able to talk a little bit about what that decision process was and why you ended up leaving?
Yeah, it did not happen overnight. I loved CDC, and I've recently disclosed publicly that I actually first thought about resigning in March. And that was after one of the first DOGE cuts. I was able to appeal and prevent the cut from being as severe as they would have been. So I stayed. But after that, I actually wrote a draft resignation letter, because I know that once you say you're going to resign, there's a good chance it will happen at some point. And so I wanted to be prepared. And then in April, things began to get worse with measles. The vaccine committee, there were a lot of questions around that. And so I knew at some point my time was going to come to an end at CDC. But I had reached out to Dr. Modernize, who was not at CDC at that time. And she promised me that she was going to come to CDC and ensure that there was scientific integrity and rigor, and to please wait. And so I honestly did my best to hold out as long as I could. I had even cleared out most of my office except for what was on the walls, because I expected that one day I'd be asked to do something I couldn't do and I would need to leave that day. And so I was prepared. Each day I came in knowing that I needed to do what I could do to protect the people of the U.S. and the world, as well as the programmatic staff. And I lasted until the end of August. And what happened was Dr. Menars did come on board. She tried to make some changes to the vaccine committee to ensure more public transparency, more scientific rigor and expertise. She was told by the department she couldn't make those changes. And when I realized that our permanent CDC director was not going to be able to make, her own decisions, I knew my time was done, that I could no longer lead or work under those circumstances. And that was really tough for me. I remember I was at the officers' service and several staff had come up to me, and I decided 2 days earlier I was going to leave. I hadn't decided when. And people came up to me thanking me for, staying with them during this time. And I got, very emotionally upset, because I already knew in my heart I needed to leave, and people asking me to stay, I felt very torn. And so I stayed for a little bit longer. But then when Dr. Menars was asked to go to DC, I knew that then her time was limited. And so I reached out to 2 of my other scientists who reported to me, who were in similar circumstances, that were dealing with the vaccine committee and some of our vaccine safety data. we decided that we were going to go out together. The three of us were working closely on a lot of issues. So they actually submitted their resignation letters to me that Monday because I was their boss, and they didn't have dates on it. And I just kept it in my inbox. And I said, we will decide when we do it. And that Wednesday, when the news came out she was being terminated, I hit submit on all three together.
Wow. That's
And we've
terrible.
been publicly speaking since then, just because for us, it wasn't just about leaving. It was where we could do the most good. And we did what we could in the agency, but we realized that over time, we were becoming less effective on the inside and could be more effective on the outside, raising it to the community, to Congress, to the media, so that people knew what was happening.
Yeah, I'd heard you say in another interview that you guys were trying to raise the bat signal to the nation and to the world. What are you trying to say? I mean,
this is not political. This is about ideology. And, when I was a transition lead, I had served under 6 CDC directors, 4 different administrations, and some of my job references are from the prior Trump administration. This has to do with people not believing data and science, being unethical and doing things that are not valid and that could hurt people. That's what concerned me, Dan, Dimitri, and many others. And so my hope is that Congress leans in. I did testify, before the Senate Health Committee around a lot of these issues. My hope is they continue to provide oversight into the allegations raised, look into them, provide much more oversight on things like the vaccine committee, look at the number of politicals being hired. There's still no permanent CDC director, and the acting CDC director has not been to CDC since having been appointed acting CDC director. That's been over 2 months. There needs to be stronger scientific leadership. And I think community members need to realize if CDC goes away or isn't effective, what's going to happen to that? There may be vaccine guidance that can't be trusted. There might be data that is delayed. There might be programs that you thought you could get at the health department on, sexually transmitted infection screening or tuberculosis protections or something around contraceptive guidance that may no longer exist because CDC's programs are being cut. And 80% of CDC's funding goes to state and local health departments. So as budget cuts happen, there's going to be a significant ripple impact across the nation and communities.
So I know that there's a lot of things that are a lot of programs that have been cut, are kind of in limbo, are on, headed for reduction in forces, and that there's a lot of that is still kind of pending litigation. But can you tell us a little bit about what programs are gone and are just completely gone at this point?
So, and some of them really don't make sense, when you're trying to think through the secretary's priorities. So one is the Division of Oral Health is completely gone. But when you look in the MAHA report, it tasks CDC with looking at fluoride. Well, that's really difficult to do when the experts and the dentists who were at CDC are no longer employed by CDC. So that's one program that's gone. The population health group that did a lot of the tribal work is completely gone. The violence prevention work is completely gone. The work in drowning, traumatic brain injuries, motor vehicle crashes is completely gone. Work in smoking and reproductive health is slated for elimination, but it's under a temporary restraining order. So those staff are on administrative leave. So those programs aren't currently functioning, but will likely be terminated. In the Global Health Center, some of the work on PEPFAR, not all of it, but some of it has been eliminated, making it more difficult to work internationally. And then when you look at some of our statistics, the National Center for Health Statistics has many programs that have been under the October reductions in force. So those staff are on administrative leave, meaning the big national nutrition survey that's done using lab data, interviewing people. I mean, one of the most comprehensive surveys ever that supports the secretary's priorities is not going to happen. So these are things that to me are kind of mind-boggling because they would support the secretary's priorities. Most of the chronic disease center is slated for elimination. If you want to end chronic disease, you don't end the chronic disease center.
Do you have an idea as to why? I mean, obviously this is an ideology now, right? But what is the ideology behind this? What is the purpose of all of this? Is it just, when I was talking with Dimitri Gaspalakis, who is a wonderful person and speaks so highly of you, he loves you, but he felt like it was more than just incompetence. He felt like that he has gone on record as saying that it is malice. And do you get that same sentiment? I don't want to put words in your mouth. I don't want to put you in an awkward position, and I apologize. But time and time again, it is, well, the secretary says this thing, but this is what's happening. So is it just dumb or is it malice?
I don't know if it's malice, but it is intentional. And when I look at the October 10th reductions in force, when they said it was a coding error, the ones that they brought back, in my mind, it's not a coding error. It's likely they got out in front and there was some pushback immediately. But to me, what it shows is that global health likely won't be at CDC. One of the secretary's advocates and friends was tweeting that, that work was slated to go to the Department of State. A suicide prevention was eliminated, and that work would be done at the new agency for AHA that, the secretary proposes to stand up. And then infectious diseases, the Center Dimitri was running, his office as a director was eliminated, was brought back. But in my mind, that means they're going to put a lot of the ID centers together. And when you eliminate ethics, HR, and the office that oversees the Federal Advisory Committee meetings, but you say that these are your priority, in my mind, that is not an error. There's something else driving it. I can't speak to what it is, but it does take the control away from the agency.
I assume that people are still talking to you from the CDC and that people are still reaching out to you. Can you give us a little bit of a sense about what is happening right now? I know that everybody's furloughed at the moment, but can you give us a sense of the feeling there?
Yeah, I think it's been very difficult for them. I was the last career in the office of the director. And so now there's really no tie for any of the senior leaders to the office of the director. So communication has been very limited. With these October 10th rifts and even the furloughs, there wasn't discussion with the senior leaders around what was happening. And they were actually crowdsourcing on October 10th to find out, where these cuts had happened. They had no advance notice and were given no summary of it after it had happened. So there's a disconnect there. I think there's also when they haven't had, I think only one person has met with the acting CDC director. It's very difficult for senior leaders, to ensure that they're, following the administration's priorities and having that, bidirectional conversations if there's not a conversation. And then certainly with the cuts with the secretary, mentioning many times, don't trust the experts. With a lot of the political leadership driving changes to things like the vaccine committee, it's extremely difficult for the scientists. There was a change to the website. If you look at the About Us website, there's a lot of political language that's on there, which CDC should be evergreen. There shouldn't be political language on it. It should be just consistent, just data, science, facts. CDC was boring. That's what it should be. It's just the boring agency that provides numbers and guidance. It shouldn't be elaborating.
If the CDC's in the headlines, there's something really, really wrong, right?
Exactly. So I think the staff, and many of them are still reeling from the shooting as well. So there's significant morale issues, trauma, repeated trauma. And so it is not in a good place. I have a lot of concerns about the dismantling of the agency and what is going to be the impact long term. And that's literally why I raised the bat signal. And I cautioned that it was going to get worse after we left. I could see the trajectory, and it unfortunately has.
So you've talked about these conversations that you guys are still having. Who are you talking with now? Who's willing to take your phone calls these days? And I know that you probably can't give specific names, and I understand that. But are they receptive? Are people listening? Do you think that there are going to be positive changes? Or is this just all doctors are somewhat optimistic at some point, and that we think that somebody is going to have this moment where they realize that they were wrong and that they need to change?
It's tough for me because I have always been that optimist. People would say I could always find that ray of sunshine anywhere. And I was at a national meeting 2 weeks ago, and I said, the sky is falling. And I do think the sky will fall if something isn't done. If there's not an intervention soon for CDC, I think the agency will be lost. I have had a lot of success, I would say, with speaking with congressional members, more one-on-one. Both Democrats and Republicans, have been very open to having those conversations. I know people complain about the media a lot, but the media, I think, has actually been phenomenal recently in their deep coverage and continued coverage of what's happening. And I think continuing to message the impact it has on people is really important. This is not easy for them to raise, I think, awareness on, because so much is going on across the nation, impacting so many sectors. But when it comes to our health, that's something, that's fundamental for all of us. And then I'd say a lot of national organizations, particularly some of the physician organizations like American Academy of Peds, ACOG, ACEP, have done a really nice job, and ACP, of lifting up these issues, sometimes even suing the government over different recommendations. Yeah. And I applaud them for taking a stand. I think we need more voices out there taking a stand right now. If the silence is not helpful in this moment, I know it's uncomfortable for people to speak up sometimes, but it doesn't have to be political. Scientific integrity is not political.
The truth is not political. It is.
Exactly. And that's what I keep saying. In the ER, I don't know who's a Democrat or a Republican. I just take care of everybody. Right. I think in public health, you take care of the communities. The focus is on the patient, the population. And that's what we need to speak up about as doctors, is we're trying to take care of people and populations. And you can't do that with inaccurate data or ideologic-driven principles.
We are living in history for sure. What is next for you?
So open to opportunities.
Open to work.
If anybody out there has ideas, no, but I formed an LLC, and I'm open to doing some consulting work. I already signed 2 contracts, and we'll have more on that coming soon. And I'm looking for board opportunities and strategic advisor opportunities where, I can use a lot of what I've learned to really, help advise things that have population level impact. My passion has always been populations and patients. I'm a mission-driven person. And I also realize that this is the time that I need to take the next few months to continue to use my voice, because I think this is an important time in history and I need to be present during it.
Well, how can people find you online if they want to reach out or, offer you a very large contract for consulting?
So I'm on LinkedIn, Deb Houry, okay. And then I'm also on Blue Sky, Dr. Deb Houry.
Okay. Wonderful. All right. Dr. Debra Houry, thank you so much for coming on. This is absolutely amazing and humbling that you would come on to my podcast. So best of luck to you. And thank you so much for your service. You are doing a great service to our country.
Thank you.
Thank you for listening to another episode of the Interesting MD podcast. Please check out my content on YouTube at Interesting MD and follow me on TikTok, Blue Sky, Instagram, Threads, and Facebook at The Interesting MD and on X at Interesting MD. If you have comments or questions and want to get in touch with me or any of my guests, please DM me on socials or email me at rob@interestingmd.com. If you have any ideas for a show and you want to share your hobbies with me or don't know where to get started on your own project, you can email ideas@interestingmd.com. Please like and subscribe to the podcast and YouTube channel to get the latest content. Much appreciation to Falter Media for editing, producing, and posting all Interesting MD content. Check them out, because if they can do this for me, imagine what they can do for you. See you next week.